What are the advanced technical developments we are working on in the clinic in the moment? And yeah, I used the police. Now you can know how old I am. Maybe I've used it here before. Seeing fast and adapting in real time, I think this fits very nicely. Every step you take, we are policing the patient. Every move you make, every breath you take, we will be watching it. And for instance, organ motion, most clinics still for the lung use this concept of huge margin. You irradiate wherever the tumor is moving to or is expected to be in this whole healthy tissue. Of course, you could do better and say, well, I wait for the tumor to be in a certain position and then I switch the beam on. This is gating. Unfortunately, in real life, these tumors are not so reliable to show up where you want them to show up. So that is a problem. And then you could do, of course, better, because you have every 200 milliseconds, we can have 3 slices of the anatomy. You could actually follow the tumor movement with your treatment beam. Also, this is not the smartest thing to do. You could track yourself into trouble if this tumor is going closer to the spinal cord or to the heart. So you have to do something called intelligent tracking, and we are just working on that. Depends how successful we will be. But I think we will see this in these new machines. What do you need for that from the technology? Obviously, you have an imaging device which is integrated with the dose delivery system right here. And now in real time, in milliseconds, you have to use all the signals you have about the delivered dose, about the monitor units you have delivered, about the gantry angle, about the couch position and everything. And then you have some software where you can actually reconstruct the dose in real time. That means in milliseconds, and I believe we will have Monte Carlo algorithms with the new technologies and computers, where I can reconstruct doses under a second in some 100 milliseconds. We can do this. And then for the first time, I know my clinical physicists don't like this, you can have quality assurance of a treatment. You know, in the moment, patient QA, in quotation marks, is done by putting a block of plastic on a couch and the patient is not even there. He's sitting at home watching TV. But with this, you could actually reconstruct the doses, see what you're delivering, and you could intervene if you see something you don't like. And then you feed this information back to the dose delivery system. And I always have to defend a little bit the strategy, and I think to make it pretty clear, what we are planning, treatment planning, is that we are predicting what the future should look like. Whatever treatment plan we make and show to the clinicians is something we never deliver in real life. It's fiction. Maybe it's not even science fiction. Maybe it's just fiction. But we need to forecast what the future will look like. I think this is the most important step, and that means that the quality is decided by the uncertainties we have between these 2 time points of planning and the dose delivery or the treatment execution. The fresher these images are, the better the treatment will be. I think that is something physicists have to teach to our clinical doctors, that they shouldn't insist on these absolute wonderful treatment plans. No dose constraint is violated because it's simply not reality what's happening to a patient. It's getting worse, I tell you. Just want to warn you, if you already don't like this, there's much more you will not like. So the quality of a treatment is really driven by prior patient data, but these data have to be as fresh as possible. It's almost with eating fruit, you know. You don't like to eat apples which are a year old, so you shouldn't do treatment planning on images which are 2 weeks old. And this is very nicely demonstrated here, I think, for the weather forecast. You see there on the left-hand side the quality of the weather forecast and then the increasing predictable time interval. If you want to predict the weather for 10 days and it has nothing to do with the computing power available, you will always be worse than you only want to predict the weather for 3 days, okay? So if we do tumor tracking, we're getting images every 200 milliseconds. I'm pretty sure I know what I'm doing and predicting it. If I do it for 3 days, I'm pretty sure I don't know what I'm doing. I made this point. And this is now an experiment, and it's also a couple of years old now. I still like to show it. This is a lung tumor followed by a radiation beam where we reconstructed the dose, and this was not just a PowerPoint movie, it was actually an experiment, in milliseconds on the anatomy of the patient. So if you have this available, this is just one building block, then real-time adaptive radiation therapy is feasible and possible. We are not there yet, but in 5 years we could do it. Whether we have it in the clinic, we will see. Good. Now, this is more the standard stuff. I think my last time I used the police is every bond you break, and that would be good if we could see that. But let's see what we can do. Anybody knows what that is? At some time I was into the Stargate, okay, and I think the MR looks like that. So I had to use that. Seeing, functional imaging, this is diffusion-weighted imaging for head and neck cancer, predicting hypoxia and so on. I think we're fiddling with this for a long time. And almost 20 years ago, Clifton Ling at Sloan Kettering came up with this idea of biological targeting using this information, converting imaging signals into different dose levels. And at that time, in that paper, if somebody, 2000, if somebody remembers it, he was predicting in 2010 we will have it in the clinic. A year later, there was the Astro meeting in Seville. He was a little bit more shaky. He said 2020. We have 1 year to go. It's not there yet. And it is this idea of spatial dose conformity to biological targets, dose painting. Is it an optimistic or a naive strategy? And I think we are all completely underestimating the complexity of biology. These images and showing them to a clinician and says, oh, there is a color blob, I want 3 more gray of dose, is simply not science. This is, wishful thinking, and that doesn't work. I think we have to learn what these images actually mean in the context of radiation therapy. And now I'm coming to something, who is working in the clinic? I have to see where my potential enemies are. Do we need new paradigms in radiotherapy? And I think we do. And this can only be done with strong new physics support and ideas. What is widening the therapeutic window? You will also, I bother you now with my childhood, educational childhood as a physicist. Do you know this guy? This is one of my heroes, Jean-Luc Picard, the captain of the Enterprise. I will give you more background, you will have. So what is widening the therapeutic window? It's basically space and time. Radiotherapy is optimized by modulation of ionizing radiation fields in space and time. And his famous sentence, and I will show you the quote, space, the final frontier. Okay, and we will see, maybe it's not the final frontier. And we have these foundations and heuristics where we concentrate all on space and we forget time. And I will make the point here, and I will make it again. If the disease cancer would be only, if the most important aspect would be space, we wouldn't need to treat any patient, because the disease is localized. If there's no progression in time, this patient could go home and stay forever like this. What is important is the development in time. And we have eliminated it completely out of our radiotherapy practice, with one exception. I will discuss it. I think we have wonderful tools, treatment-integrated imaging, dose delivery devices, Monte Carlo dose calculations. I don't want to name them all. But on the clinical side, we have this heuristics, beliefs, habits, and traditions which are not very well founded. For instance, the dose damage is local. If there's one voxel getting a dose of 60 gray and there's another one of 60.5 gray next to it, we assume that the damage done in these volume units is just local. We know it's not true from biology, but this is what all our models reflect. Then the target dose needs to be homogeneous in space within a magic interval. Nobody knows why it's 95% of the prescribed dose, 107. And everybody talks about tumor heterogeneity. It's as heterogeneous as you can think of, but no, we want it homogeneous. Doesn't make any sense whatsoever. Dose between fractions can be accumulated or has to be accumulated. I will demonstrate to you this is absolute nonsense, and it will never occur. The dose, there is a CTV, a funny volume, the clinical target volume, describing microscopic spread accurately, and it needs the same dose at the gross tumor volume. First, you cannot see this volume, that's why you have to draw it. That makes sense. Don't know how this. And then because there are less tumor cells, it needs the same dose. Why is that like this? I think nobody knows. The geometric uncertainties can be accounted for by margins. If there's one clinician who understands the Marcel von Herk recipe, I give you 10 pounds or half of my salary of a month. And the DVH constraints, dose volume histogram constraints, are the guardian's metrics of plan quality. These are all beliefs which are deeply in the brains of the community we are working on. And fractionated radiotherapy needs to be administered with equal doses, each day the same dose. This is our dogma. So I think we are focused on the spatial imaging signals, and we just want to convert them to different dose levels. But these heuristics are our mantra. And I believe if we would get one or two of these constraints, if we loosen them, maybe we win much more than with any proton facility we can ever build. So let's discuss it. I think we are spatial dose experts or maniacs. And I had a very depressing moment at an Astro meeting. I don't remember exactly when it was, so I said 2015-16. And there was a debate. What is more important in radiation therapy, 1 millimeter spatial accuracy or 1% accuracy in the delivered dose? And I believe none of that is important whatsoever. Why even discuss it? But there's a professional society who comes up with this topic. So, and now I like this quote. In general, expert trends analysis become introverted and narrow. It's one of my favorite Canadian authors, and sometimes results in false sophistication. And the complexity of our methodology lets us forget how naive our assumptions are. And what I had before were the naive assumptions, okay? But we are now bringing them down, measuring dose to 0.5%. This is just incredibly naive that will make a difference. So